female colorectal cancer patients, they do seek female healthcare practitioners with a specific eye for this. So I think it's really good that there's more representation in my generation of surgeons, of women who actually advocate for their patients.
Welcome to Caring and Sharing, the Advanced Oncology Podcast. My name is Uta Schmidt Strassburger and I am meeting Professor Gabriëlle Van Ramshorst today. She is a surgeon at Ghent University Hospital and an associate professor at Ghent University. Also, she is very scientifically active in different scientific societies that cover her area of expertise. Welcome.
Thank you so much for the kind invitation, Uta.
I'm very happy to have you here. We recently met online at a global cancer movement event that covered colorectal cancer, which happens to be your area of expertise. And you were giving a presentation on sexual health of colorectal cancer survivors. And I would like to learn more about that and share what you've been talking about with our listeners.
Yeah, thank you very much. And indeed, I think sexual health, especially in female patients, really deserves to have more attention also in the follow-up of these patients. What we've seen also from our own research, that it's quite difficult to both get patients talking about sexual health because the patients feel embarrassed to initiate the conversation. But we also seen that healthcare professionals feel that they've been inadequately educated on how to have these conversations with patients. We saw from a survey which was done by Kom op tegen kanker, which is like a Belgian cancer society, that 70% of the patients actually wanted to have these conversations about sexual health and intimacy problems. They reported also that 87% of patients at some stage of their trajectory have problems with their sexual health and intimacy. And this really affects the relationships with the partner as well.
How do you address these topics with a patient if they are coming to you for a first consultation? Are they being referred particularly to you? So are you already known for your attention to the intimacy problems that might arise from a surgical intervention in colorectal cancer? Or how should I imagine the scenario?
Of course, we have our own gastroenterologists who diagnose the colon and the rectal cancer patients. For those patients, I think for colon cancer, the situation's often a little bit less relevant upfront because most of these patients are not treated with any neoadjuvant therapy. However, if the patient has a rectal cancer, quite quickly we have a conversation usually about neoadjuvant therapy, which would usually involve both chemotherapy and radiotherapy. And of course, the surgery itself, which will come at a later phase, can also negatively impact on the patient's sexual function, especially in women who are still in the reproductive age. You know, the chemotherapy can induce ceasing of the menstruations. And the radiotherapy, especially if the ovaries lie close to the cancer, they can become sterile. So these patients need to be counseled about fertility preserving options before they even start the chemotherapy or the radiotherapy. This is also true for men who can have fertility issues and they may need sperm banking, for instance, before they start the therapy, which can have a gonadal toxicity effect.
We have recently observed a shift towards early onset colorectal cancer. Does this affect men and women equally in your experience?
It's difficult to say because the rise in the early onset colorectal cancer has been quite notable. And to my understanding, I've not been aware that there's a gender difference in terms of the early onset colorectal cancers because I've seen it both in men and women. And we generally say that early onset colorectal cancer is before the age of 50. So, of course, the women who are still of reproductive age, they might get therapy-induced menopause.
I also think that fertility preservation is different. It is more straightforward for men than for women. So I think it does need a little bit more of elaborate planning for the women who are going to undergo treatment. How much of a delay does this usually create? And are there women who are opting out of the fertility preservation?
Well, of course, you have to ask these patients whether, it might be relevant if they have a partner. Also, if they don't have a partner, these discussions can be relevant. And also, you never know what might happen in the future, right? So there's a risk of the relationship ending. We know that that happens more frequently in women than in male patients, that they're abandoned by their partners. So they might have new partners in the future with whom they might want to have a family. Also, there can be concerns from the patient side, especially if there's some genetic predisposition for cancer, that they're afraid that, if they do reproduce, they will have this genetic defect being given to the next generation. So that might be some hesitance there also to counter this. But I think for the most part, the cancer diagnosis itself causes so much stress and people are so focused on today and tomorrow that it's very difficult to think about what will life be 2 years after surgery, 5 years after surgery, 10 years after surgery. And the delay that's caused is usually not too long, maybe 2 weeks, depending also if you're going to cryopreserve ovaries and you really want to have oocytes or embryos. The ovarian transposition can usually be arranged quite quickly. That will be a laparoscopic procedure. But of course, that is a really vulnerable process if these referral patterns to your reproductive services are not well embedded in your hospital. And also, you need to think about this as a physician. And sometimes the nurses can be really helpful as well. We've seen also that some patients are more comfortable speaking to nurses than speaking to physicians on sexual health and also these fertility issues.
You presented some work where you have recently interviewed healthcare providers, how comfortable they are in discussing sexuality with cancer patients. What you found out, among others, was also that some healthcare providers feel not sufficiently equipped to discuss these issues also with members of the LGBTQ plus community. Would you like to elaborate more on that?
It's interesting because, first of all, we ourselves counted some barriers in even getting permission from our institutional review board to perform this type of research. And also at that time, we were more focused on also interviewing patients themselves. Interestingly, there was a psychologist in the institutional review board that kind of accused us of voyeurism. And we were really unprepared for that concept, as we're really focusing on needs and unmet needs of these patients. Because you can imagine that if, like the regular cis hetero patients and couples, they already have barriers, then it's even more difficult for patients in the LGBTQ plus population. We know from epidemiological research is that there's less participation from the LGBTQ plus population also in screening programs, and they may be more reluctant to seek help. Whereas, for instance, for some types of cancer, some of the subpopulations of the LGBTQ plus would be like a higher risk of developing these cancers. Then again, the LGBTQ populations might have even like more than one partner, for instance, that can be common in some subpopulations. Or they may be more likely to be accompanied by a friend, for instance, than by a partner or a mother or a father, especially if they're young. And they might be more reluctant to come out of the closet because even though a lot of healthcare practitioners think that they're very open and they're very inclusive, that may not be the perception of the LGBTQ plus patients. And that can be sometimes easily solved by asking the patients about their pronouns or having, for instance, an LGBTQ flag. But it's really not so clear to many patients whether they're actually in a safe environment with the healthcare practitioner. So that's an extra barrier that can be encountered. And a lot of the educational materials that exist on discussing sexuality focus much more on the heterosexual patient and heterosexual practices. And for instance, if you look at anal receptive sex, that can be quite common in some gay couples. But for instance, we know it's also relatively common in heterosexual couples, so about 20%. But not a lot of people actually feel comfortable discussing it or assuming it or asking about it. And we're even not maybe really sure, even if you have a low anastomosis, how harmful it can be to have anal receptive sex. But we also saw that the healthcare practitioners, they felt less comfortable talking about sexual health with patients who had different religious beliefs, patients with physical handicap. And just because they were unsure what to do, then they just did not discuss it at all out of like a fear to maybe make mistakes.
But your survey also showed that if you educate the healthcare providers, they feel more at ease discussing these issues, right?
Yeah, not only do they feel more comfortable talking about this, but they also make less other assumptions. Like, for instance, that it's difficult to find the right space to have the conversation, or that they assume that the patient is not comfortable to talk about this. So there's many spoken and unspoken assumptions, and maybe even like cultural rules, how to
Mhm.
engage in these conversations. But a lot of educational models, they would suggest to ask for permission to talk about the subject, and then to continue. And what I usually do is that I go from a surgical angle.
Mhm.
For instance, I say like, well, this is the anatomy, and here are the nerves going to the bladder and to the prostate or to the vagina. And during the surgery, we these nerves, can be harmed, and this might result in bladder retention or less lubrication or erectile dysfunction. And then I can progress into, so how are your erections right now? And are your erections rigid enough? Do you have ejaculation, etc.? And how's your bladder function? And can you empty your bladder totally? And that brings out kind of a natural way to discuss the sexual health as well.
You also mentioned in our previous discussion that you do have sexuologists on retainer. And I would like to learn more about that because in our comprehensive cancer center, we do have the psycho-oncologists who cover quite a lot of sexual health as well. So I do know from my colleague in the psycho-oncology group and in our liaison centers that they are usually approached with these questions. Oh, and I am not certain how many of our patients are approaching these questions up front. So, of course, I would like to learn more how the procedure is in Belgium.
So specifically in our university hospital, and the position of our hospital is a bit strange because we're actually the only government-owned hospital, and we cover the east of Flanders. We also cover a lot of the west of Flanders, some southwards up to the French border, and then about up to the area of Brussels. And we also cover the southwest of the Netherlands, as we're the closest academic center for that area as well. And in our cancer center, we also offer, for instance, transgender surgery. So there's psychologists attached to that as well. And we have a specific set of oncopsychologists. And then we have the oncosexuologist and also like the regular sexologist. So if for instance, that happens more with the female patients, I think. If they keep encountering issues with their partner, or they experience stress, and or the communication is not optimal with their partner, I usually suggest to refer them to the sexologist to have a conversation there, and that can be with or without their partners, because I can sense that the male partners are sometimes, not always, more reluctant to speak about sexuality than the female patients. There are a lot of barriers as well, because especially if the female colorectal cancer patient has a stoma, they can feel quite embarrassed about the stoma. The stoma sometimes, can make some noise, or there can be some gas, and there's a bag attached, and they might need some lubrication agents, or some vibrators also if they really want to use those. So there's more planning involved. What positions are you going to take? Is that the same position as you used to or not? And will your partner still find you attractive? What if anything goes wrong? What if you don't have a stoma, but your sphincter function is not optimal? You might be very afraid that if you're deeply relaxed, you will also pass some gas or stool. Yeah, there's a lot of different aspects to this. And also, if you're not completely relaxed, Can you really enjoy the sex, or maybe you're in pain, but you don't want to disappoint your partner because you're afraid that your partner might, seek outside of the relationship for sexual contact. Yeah, it's very challenging, and offering these patients some extra help, whether that's nurse-led, whether it's psychology-led or sexuology-led. Most important thing is that you're not afraid to discuss it. And I feel, as I'm serving a lot of female colorectal cancer patients, and some of them come to me as second opinions, that they do seek female healthcare practitioners with a specific eye for this. So I think it's really good that there's more representation in my generation of surgeons, of women who actually advocate for their patients.
Fortunately. So you already touched upon the subject that a cancer diagnosis can be strenuous for a relationship, and that there seems to be a shift that female patients are being left more easily by their partners than male patients. So if a male patient, cancer patient, is falling ill, then the partner is taking care of him. But it seems that the opposite is not always the case. Would you like to elaborate on that?
First of all, sexual dysfunction is experienced by about 65% of the patients with colorectal cancer. And it's not just the having the cancer and having the diagnosis, but it's also the fatigue, the depression. Women are more likely to have depressive symptoms. And then, of course, it's the effect of the radiotherapy, maybe the menopause or limited libido, the chemotherapy, but there's also a lot of impact on the communication with the partner. And we should not forget that not every relationship is actually a happy relationship. Even before the cancer diagnosis, partners can be absent, whether that's physically or emotionally absent. And especially if there's a lot of pain regarding the diagnosis, people find ways to escape from pain. And that could also be in initiating affairs with other people. And there can also be abuse in relationships, like physical or emotional abuse. We know from a German publication from Nalband in Frontiers in Psychology from May 2021. They interviewed nearly 300 partners of cancer patients, and about a quarter of these couples had separated. And they said that in nearly 60% of those cases, cancer actually contributed to the separation. And the couples that did not separate, we find that the effect of the cancer on the relationship was positive in 37%, but it was also negative in 47%. I cannot read a man's mind. I'm not sure if that's good or bad, but I do feel that maybe women require more conversation about their emotions, and they're less likely to suppress all these emotions. And also the support systems of women, they tend to be larger. I think whereas the men, they usually have their spouse. We know that, as we discussed earlier, married men live the longest and single women. So there's certainly differences in these dynamics. And I've also heard from colleagues who have more research background in breast cancer patients that also in qualitative interviews, it is more likely that patients with breast cancer are afraid of being abandoned during their relationships. And you can imagine, of course, with the breast also being important for sexuality, as maybe like not having a stoma, that these are factors that create extra stress for women.
Yeah, I totally agree that this is an additional factor. I would like to close out with a quote from Jane Goodall. It does not take very much to be called a complicated woman. This is why there are so many of us. And I do think that probably many of the women who are being abandoned could be called by more emotionally distant people complicated or stressful, but why are you being complicated? But they are just being themselves, and I think it is their right to be as they are. And so I certainly hope that all the different options that are there for treatment from the medical oncologist or from the internal medicine specialist, gastroenterologist, the surgeon, and the sexuologist, or in our case, the psycho-oncologist, that they will contribute to a better well-being of the patients. So thank you very much for this very inspiring conversation, and I'm looking forward to meeting you in person. I've already learned a lot.
Thank you so much for the invitation, and good luck with your series.
Thank you.